Now, the ATA, American Thyroid Association 2021 guideline emphasize aggressive early interventions and early genomic testing for anaplastic thyroid carcinoma to guide therapy, thus moving away from the previous nihilistic approaches. Uh, these are the differential diagnosis of anaplastic and poorly differentiated thyroid cancer. This is the panel of routine IHC marker that helps differentiate ATC from other thyroid and non-thyroid tumors based on IHC profiles. Differentiated thyroid cancer is cancers are characterized by strong positivity for thyroglobulin, TTF1, and PARX8 with a low Ki67 index. Poorly differentiated thyroid cancer, as we see, is similar to differentiated thyroid cancer, but with a higher Ki67 index and variable thyroglobulin expression. Anaplastic thyroid cancer, there is loss of differentiation markers. They have lost all the differentiation markers like thyroglobulin and TTF1 with variable PARX8 and very high Ki67, which is more than 30%. Medullary thyroid cancer is they are uniquely positive for chromogranin, calcitonin, and CEA. Squamous cell carcinoma patients are strongly positive for pancytokeratins and negative for thyroid specific markers. Whereas lymphoma, as we all know, are positive for CD45 and they have variable Ki67. This is a general schema for approach to patients of anaplastic thyroid cancer. It focuses on urgent diagnosis and staging due to the aggressive nature of this tumor. Targeted therapy is recommended for BRAF mutated cases, while wild type cases are managed with supportive or palliative interventions. It includes multidisciplinary approach, which ensures optimal patient care and symptom management. Now, what are the clinical presentation of patients of anaplastic thyroid cancer versus poorly differentiated thyroid cancer? Anaplastic thyroid cancer patient usually presents with rapidly worsening symptoms, including a hard, fixed neck mass, severe neck pain radiating to the ear, hoarseness, dysphagia, stridor. They'll have extensive lymphadenopathy, frequent distant meds, and systemic symptoms like weight loss, fatigue, which indicate aggressive progression. In contrast, poorly differentiated thyroid cancer, they typically progress slower, presenting with an enlarging but less fixed neck mass, less neck pain or tenderness. They will occasionally have hoarseness or dysphagia due to local invasion, and they have less frequent metastasis and systemic symptoms only in advanced stages. Fine needle aspiration cytology is recommended for initial evaluation of anaplastic thyroid cancer or per se for all thyroid cancer. But core biopsy may be necessary for definitive diagnosis and sufficient material and requirement of sufficient material for molecular testing. Molecular testing should be done at ATC pace. The two known faster testing methods are BRAF by immunohistocytochemistry and liquid biopsy. ATC progresses rapidly and therefore it requires fast molecular testing to guide therapy. BRAF immunohistochemistry offers a rapid result within 1 to 2 days, while liquid biopsy for circulating cell-free DNA provides non-invasive testing within a time around 10 to 14 days. Every effort should be made to establish a diagnosis by biopsy before proceeding with surgical resection, as surgical resection may be inappropriate. A biopsy first approach ensures appropriate patient selection for surgery, and it also includes avoidance of unnecessary surgical risk in cases where systemic therapies are better options. Surgical pathology should confirm anaplastic thyroid carcinoma. It assess disease extent, identify coexisting differentiated thyroid cancer, and document the proportion of ATC present. Tumors with smaller anaplastic component often have a better outcomes, making it essential to quantify the percentage of ATC within the tumor. Identifying coexisting DTC is essential to confirm the ATC that is essential to confirm that ATC arose via dedifferentiation. It may influence therapy such as targeted treatment for DTC component. Now, what is the role of medical imaging in poorly differentiated thyroid cancer and anaplastic thyroid cancer? Sonography and fine needle aspiration biopsy is used for initial diagnosis. Preoperative evaluations such as esophagography, bronchoscopy, vocal cord assessment are critical for detecting extrathyroidal extension. CT MRI, it helps evaluate local invasion and relationship between tumors and surrounding structure. Cross-sectional imaging should be done beforehand for staging. Iodine 131 whole body scan. It is used for detecting iodine-avid metastasis, but it has a limited role in dedifferentiated tumor due to impaired sodium iodine sympod trafficking. 18 FDG PET CT is essential for detecting iodine refractory distant mets for planning radiotherapy and monitoring treatment response. Biopsy of distant lesion is unnecessary if the primary tumor biopsy provides a diagnosis and molecular testing material. Now, this is the staging for anaplastic thyroid cancer. As we see, anaplastic thyroid cancer straight away falls into stage 4. Stage 4 lesions are tumor, those are confined to thyroid gland T1 to T3A with no regional lymph node and no distant metastasis. Stage 4B tumor which extend beyond thyroid capsule, T3B and T4 tumors, and it involves regional lymph node but with no distant metastasis. And stage 4C tumors are tumors of any size or local invasion with or without lymph node involvement and presence of distant mets. This is the staging for general TNM staging for poorly differentiated thyroid cancer. T1, which is less than 2 centimeter, T2 tumors 2 to 4 centimeter, T3 tumors are those which are more than 4 centimeter limited to thyroid, limited to thyroid or gross extrathyroidal extension, invading only strap muscle. T4 tumors are those which include gross extrathyroidal extension into the major neck structures. For nodal staging, it includes N0A, N0B. N0 are those with one or more cytological or histologically confirmed benign lymph node. N0B with no radiologic or clinical evidence of locoregional lymph node metastasis. N1A are those with metastasis to level 6 and 7, and N1B with rest of the compartment of lymph node. Okay. All ATC patients should undergo vocal cord evaluation at presentation and during follow-up if symptoms change. It is strongly recommended. Now, when to involve palliative care and when to involve hospice care. Palliative care should be initiated early in the treatment of anaplastic thyroid carcinoma. It enhances patient comfort. It addresses emotional, psychosocial, and spiritual concerns. Hospice care is appropriate for patients who decline life-prolonging therapies and prioritize dignity and quality of life during end-of-life care. Now, coming on to treatment of poorly differentiated thyroid cancer. Total thyroidectomy with or without central or lateral neck dissection is preferred approach for clinically or radiologically suspicious lymph node is the standard clinical approach. However, the benefit of adjuvant treatment remain inconclusive. We still don't have any standardized guidelines due to the rarity and heterogeneity of poorly differentiated thyroid cancer. Surgical management of anaplastic thyroid cancer. Uh, who are the surgical candidates for anaplastic thyroid cancer? Stage 4A and 4B patients who have locoregional disease, and selected stage 4C patient for palliation or preventing complications such as airway obstruction. What is the resectability criteria for anaplastic thyroid cancer? It is considered resectable when locoregional disease such as stage 4A, 4B is present without distant mets, and where R0 resection and R1 microscopic residual tumor resection is possible.
And of course, this extends to all our patients with recurrent ovarian cancer.
Radical resection is generally not recommended for anaplastic thyroid carcinoma given the poor prognosis of this tumor. What is the optimal extent of surgery? Total or near total thyroidectomy is preferred for resectable disease. Lobectomy may be considered if there is ipsilateral recurrent laryngeal nerve injury or parathyroid involvement, while prophylactic neck dissections are not recommended. Surgery should prioritize complete resection, which is R0, R1 for prolonged survival. As surgical intervention in anaplastic thyroid carcinoma extend the median survival from 3 to 8 months, with complete resection enhancing overall and disease-free survival when combined with adjuvant therapies. However, extensive upper aerodigestive tract involvement often preclude curative surgery, necessitating individualized assessment. Extent of surgery during intraop. This ensures real-time assessment of tumor margin status to maximize R0, R1 resection outcomes. In anaplastic thyroid cancer, tracheostomy is primarily indicated for palliative management of airway obstruction only. Preemptive tracheostomy is not recommended without impending airway compromise due to risk of bleeding, tumor regrowth at stoma, short airway patency, and potential delays in radiotherapy or systemic therapy. Debulking surgery in anaplastic thyroid carcinoma aims to reduce tumor burden when complete resection is not feasible, but it may delay adjuvant therapies due to wound healing, and it offers limited survival benefits. Neoadjuvant therapy, including external beam radiotherapy or combined chemoradiotherapy, can downstage unresectable anaplastic thyroid cancer, potentially enabling delayed resection. For adjuvant setting, initiating adjuvant chemoradiotherapy within 2 to 3 weeks post-surgery is crucial to prevent disease progression in anaplastic thyroid carcinoma. Now, for patients with anaplastic thyroid cancer who have undergone complete R0 or near complete R1 surgical resection, the following considerations are pertinent. Combining surgery with post-operative radiotherapy with or without chemotherapy yields the best survival rates. Administering high-dose radiotherapy is associated with enhanced outcomes. Trimodal therapy, which includes surgery, radiotherapy, chemotherapy, has been shown to improve survival rates more effectively than bimodal therapy.
So if we are testing patient on the surgical specimen, many patients will not derive this benefit.
Now, systemic therapy consideration. For initiation of cytotoxic chemotherapy, it can commence within 1 week after surgery, provided there is sufficient healing. This approach prepares patient for subsequent chemoradiation therapy. therapy can achieve local control even in unresectable or R2 resected patients.
For germline testing, is it safe to say that if the HRT test is negative, most of those treatments will have
Following R0 or R1 resection, patient with good performance status and no metastasis who desires aggressive treatment should receive IMRT with concurrent systemic therapy. In patient receiving definite intention radiation, cytotoxic chemotherapy with taxane alone or in combination with anthracycline or platinum agent is recommended. Aggressive multimodal therapy is recommended for patients with good performance status and loco-regionally confined disease. For patients with unresectable disease who are rendered resectable post-therapy, surgical resection is strongly recommended for unresectable ATC patients who are rendered resectable post-therapy. Low-dose radiotherapy is strongly recommended for symptom control in anaplastic thyroid cancer patients with poor performance status. Early initiation of cytotoxic chemotherapy is suggested for patients with unresectable or advanced anaplastic thyroid cancer as a bridging approach until results of molecular testing or targeted therapies become available. This approach aims to control disease progression during interim period before more specific treatment can be administered. Now, a word on systemic targeted therapies. BRAF mutated anaplastic thyroid cancer is treated with FDA approved dabrafenib and trametinib, showing high response rate of around 61% and good survival benefits. It is used in unresectable or metastatic anaplastic thyroid cancer and also has neoadjuvant benefit. This targeted therapy represents a major advancement in the treatment of anaplastic thyroid cancer, offering a significant survival advantage for a subset of patients with aggressive cancer. In BRAF mutated stage 4C patient and in unresectable stage 4B anaplastic thyroid cancer patient who decline radiation therapy, initiation of BRAF or MEK inhibitors is recommended over the systemic therapies if available. In unresectable BRAF mutated stage 4C patient in which radiation therapy is not feasible, chemoradiotherapy or neoadjuvant therapy may provide alternative to initial therapy. So in short, for patient with unresectable stage 4B or 4C patients who has BRAF mutations, BRAF or MEK inhibitors are recommended as the preferred systemic therapy in BRAF mutated anaplastic thyroid carcinoma. For non-BRAF mutated anaplastic thyroid cancer patients, in BRAF non-mutated patients, radiation therapy with concurrent chemotherapy should be considered in an effort to maintain the airway in patients with low burden of metastatic disease. For loco-regional control, radiation therapy with chemotherapy is prioritized, particularly for cases involving the airway or esophagus. We have additional targetable fusions like NTRK fusions treated with TRK inhibitors, red fusions molecule like selpratinib. These are FDA approved, treated with red inhibitors, ALK fusions. For novel therapies, participation in clinical trials for emerging targeted agent is strongly recommended. These strategies underscore the importance of personalized medicine in managing ATC, aiming to improve patient outcomes through targeted interventions. The use of TRK and RET inhibitors for patients with NTRK or RET fusion positive stage 4C anaplastic thyroid cancer patient, initiation of TRK inhibitors or RET inhibitor is suggested preferably within these are preferable within the context of clinical trials only. Anti-angiogenic drugs like lenvatinib shows modest efficacy in anaplastic thyroid cancer. It has got 24% response rate and 10.6 months of survival benefit. But it carries a high risk of bleeding of fistulas in invasive tumors. So patient must be warned of these complications.
Genomic star score was high, and hence it was reported as an HIV positive case. So the
Uh,
cutoff for
we have checkpoint inhibitors like PD1 and PDL1 inhibitors. They have shown significant benefit, ideally in clinical trial for patient with 4C, for patient in 4 stage 4 anaplastic thyroid cancer. Uh, in ATLAB trial, a combination of lenvatinib and pembrolizumab improved median overall survival over single agent lenvatinib. Thus, immunotherapy is more effective when combined with targeted therapy as suggested by retrospective data. The primary clinical challenge in poorly differentiated thyroid cancer is the management of distant mets, which are often refractory to conventional treatments like radioactive iodine and systemic therapies. Given the biological overlap between poorly differentiated thyroid cancer and anaplastic thyroid cancer, patients with poorly differentiated thyroid cancer should be included in future clinical trials focused on anaplastic thyroid cancer. This inclusion will help explore the potential benefit of novel therapies in both the diseases. Moreover, it should get enrolled in basket studies, which focus on treating cancers based on the genetic mutations, not their location or type. For metastatic anaplastic thyroid cancer, patients lacking other options like cytotoxic chemotherapy uh, with taxane and anthracycline or taxane with or without platinum agent is suggested. This approach provides palliative benefit by potentially slowing tumor progression and improving symptom control through survival benefit. Tyrosine kinase inhibitors like sorafenib and lenvatinib are approved for radioiodine refractory differentiated thyroid cancer, while combination of dabrafenib and trametinib is approved for inoperable or metastatic anaplastic thyroid carcinoma. Additionally, agents like selumetinib and panobinostat have shown potential in restoring RAI uptake by activating the sodium iodine symporter. Uh, Tumor infiltrating lymphocytes and CAR T cells. Uh, these both are being explored for the potential in personalized cancer immunotherapy. Uh, Now, in brief about the approaches to brain and bone mets in anaplastic thyroid cancer. The prevalence of brain metastasis in anaplastic thyroid cancer is around 1 to 5%. Uh, the median survival after brain mets is around 1.3 months. Surgery combined with radiotherapy may extend survival to around 9 months. Uh, for management of brain mets, surgical resection improves quality of life and neurological symptom. Gross total resection is associated with better survival than subtotal resection. Stereotactic radiotherapy is preferred for most patients with solitary or few lesions. Whole brain radiation therapy is used for multiple lesions. Dexamethasone is recommended for patients with compressive symptoms. The use of systemic therapy for brain met is limited, but dabrafenib may be used for BRAF mutations. Supportive care includes seizure precautions and safety counseling. Moving on to bone metastasis. The prevalence of bone mets is around 5 to 15% of anaplastic thyroid cancer. FDG PET or whole body MRI is preferred for detecting metastasis. For management, palliative radiotherapy is strongly recommended for symptomatic metastasis. With orthopedic fixation is advised for structural compromise before radiotherapy. Uh, Bisphosphonates and bisphosphonates or rank inhibitors are available with calcium and vitamin D are conditionally recommended to prevent skeletal mets. Uh, Alongside pain management and radiotherapy or interventional approaches are recommended. Oligoprogressive metastatic disease. For progression in less than equal to 5 metastatic sites, we consider local therapy to delay systemic changes like SBRT and radiofrequency ablation. We avoid surgery in such cases. Pembrolizumab may be added. This diagram outlines the initial treatment strategies for anaplastic thyroid cancer patient. For stage 4A and stage 4B, we'll talk in detail about the management approach. This for stage 4A patient, which is locally advanced, uh, they strongly recommend definitive intention therapy for long-term survival. Surgery is recommended for stage 4A patient only if R0 and R1 resection margin is possible, and we avoid laryngectomy and debulking surgery in stage 4A patient. Then only we recommend surgery for stage 4A patients. This is followed by intensity modulated radiotherapy plus minus chemotherapy. Uh, Coming to stage 4B, here we first assess the resectability of the tumor. We perform rapid BRAF assessment and comprehensive genetic testing to determine mutation status. If the tumor is resectable, surgery is generally preferred. The goal again here is to achieve R0 and R1 resection without unnecessary debulking. If resection is not possible, we check for mutations like BRAF mutation.
पापा
If BRAF mutation is
आप
present,
कॉफी लाने
we
वाले थे
initiate
ना
dabrafenib and trametinib.
कॉफी और वो उससे पूछ लो अगर फोटोकॉपी हुआ
And
हो
for
तो
other tumor genetics like ALK or NTRK or RET fusions,
मैं अभी
we
पंच
consider
करने
targeted
जाऊंगी
therapies.
क्लास खत्म होने के बाद
If there are no targeted options, then we proceed to definitive radiations like IMRT plus minus chemotherapy. We then again assess tumor response post-treatment. If there is an excellent tumor response post-targeted therapy, we consider surgery. We reconsider surgery if there is good response after post-treatment. And if post-response, if post-treatment we have poor response or no further therapeutic options are available, we shift to palliative chemotherapy or radiation or best supportive care or hospice. Then we have additional recommendations. Clinical trials is strongly encouraged at any point in the treatment algorithm, especially when standard therapy fails or novel targeted therapies are available. Best supportive care can be offered throughout the treatment. Now moving on to stage 4C anaplastic thyroid cancer. Here we see that if aggressive care is desired or not. If not, then we move to best supportive care or hospice treatment. If yes, then we initiate evaluation for potential systemic therapy and genetic mutations.
Do we need to do HRE testing or can we
For genetic and molecular testing, we perform BRAF assessment and comprehensive genomic testing to determine actionable mutations like ALK, NTRK, and RET fusions. If BRAF mutations are present, then we initiate dabrafenib and tremetinib. Then, after starting these drugs, we evaluate the response. If the response is favorable, we consider consolidative therapy like surgery or radiation if feasible. If the response is not favorable after starting BRAF mutation, then we explore other targeted therapies or supportive care options. Okay, and then if BRAF mutation was absent, uh, then we would have proceeded to test for other actionable tumor genetics or high tumor mutational burden. And if there are no actionable mutations found, we shift to palliative cytotoxic chemotherapy or radiation, or offer best supportive care or hospice. Then again, clinical trial is strongly recommended at any point if possible in treatment of anaplastic thyroid cancer. Bridging cytotoxic therapy is considered while awaiting genomic result or targeted drug availability. In cases of favorable response, consolidative treatment like radiation or surgery may be pursued to manage residual disease. The prognostic factors for anaplastic thyroid cancer and polydifferentiated thyroid cancer. Uh, Positive prognostic factors are age less than 65-year, tumors which are intrathyroidal with no mets, smaller tumor size with less than 6 centimeter, um, tumor where complete tumor resection is possible, followed by radiotherapy or chemotherapy. Negative prognostic factors are those with age more than 70 years, patients with extrathyroidal invasion, presence of distant mets, and tumor size more than 7 centimeter. This table effectively compares the key features between polydifferentiated thyroid cancer and anaplastic thyroid cancer. Polydifferentiated thyroid cancer, as we see, they still have partial resemblance to normal thyroid tissue, while anaplastic thyroid cancer completely loses thyroid characteristic, looking entirely undifferentiated. Based on histopathology, polydifferentiated thyroid cancer has intermediate features like cellness, trabecular patterns, while anaplastic thyroid cancer looks chaotic with pleomorphic and undifferentiated cells. Uh, Based on thyroid markers, polydifferentiated thyroid cancer retains some of the markers like TTF1 and thyroglobulin, while anaplastic loses all the specific markers, all the specific thyroid, all thyroid specific markers. Based on aggressiveness, uh, polydifferentiated thyroid cancer is moderately aggressive, while anaplastic thyroid cancer is extremely aggressive. Polydifferentiated thyroid cancer has limited necrosis, while anaplastic thyroid cancer shows extensive necrosis. Based on clinical behavior, um, polydifferentiated thyroid cancer tends to invade locally with moderate risk of spreading, while anaplastic thyroid cancer grows and spread very quickly with early metastasis. The survival rate for both polydifferentiated thyroid cancer, it has 50 to 60% survival over 5 years, while anaplastic thyroid cancer, it has very poor survival with a median of 4 to 6 months. So polydifferentiated thyroid cancer is a moderately aggressive thyroid cancer, partially retaining thyroid features, while anaplastic thyroid cancer is highly aggressive cancer that completely loses thyroid characteristic. It grows very rapidly and it has a very, very bad prognosis. To conclude, anaplastic thyroid cancer and polydifferentiated thyroid cancer remains a formidable oncologic challenge. Despite its grim prognosis, advances in diagnostic tools, genomic profiling, multidisciplinary treatment approaches offer some hope for improving outcome. Thank you.
Presentation has been quite exhaustive and you have covered pretty much each and everything. Actually, it was a pretty good presentation. You have covered all the topics and all the questions and queries, like frequently asked questions which are dealt with anaplastic carcinoma patients have been dealt in your presentation. So that's a great part.
Thank you, sir.
Something which I would like to comment upon is that so a lot of discussion has been done on molecular markers, molecular genetics, and so they're really good for academic exercise for these patients. But what we have to understand that anaplastic patients, when they walk in our OPD, they come with a set of signs and symptoms which tell us ki, okay, this is in most likelihood an anaplastic CA, right?
Yes, sir.
See, anaplastic CA will be diagnosed in two conditions. One, you have done a surgery, okay, for a patient which was diagnosed as Bethesda 6. You have operated the patient. It has come out to be some differentiated tumor or medullary CA with focus of anaplasia. Right? It's called a collusion tumor.
Yes, sir.
Or you can get anaplastics. The patient walks into an OPD, neck is stuck, large thyroid gland, bilateral nodes. Patient is having some difficulty saying that it has progressed in last 1 month, 15 days. You know it is anaplastic cancer, right?
Yes, sir.
So what is to be done now? Will you advise the patient, okay, go get your FNSC done, get the MRI done, and meet me in next OPD on Monday or Tuesday or Wednesday, whenever it is? Or is there any other intervention that you would like to think for in this patient? Anyone? So basically, anaplastic patient, if it walks in your OPD, you know that it is kind of a medical emergency, okay?
Yes, sir.
So ideally what we have to do, we have to expedite all the investigations as fast as possible. You have to talk to the pathologist, you have to talk to the radiologist, get the core needle biopsy done today, get the frozen section report done today. If it shows poorly differentiated or features of anaplasia, admit the patient or counsel the patient and the family about the condition of the disease. So if patient present with this kind of disease, which is where the neck is stuck, we know it is 4B at least, right?
Yes, sir.
So we have to explain it to the patient what are the goals of treatment. They have to know that the survival is poor. Survival is not great. So herein comes the role of breaking bad news. It is very important in cases of anaplastic CA, right?
Yes.
So you have to break bad news properly. You have to ensure that the family understands, patient understands. You have to, do you understand what is advanced directive?
So,
Can anyone tell me what is advanced directive? Dr. Shikha, Dr. Vijay, Dr. Rizul, Dr. Jasdeep, anyone? See, for any anaplastic CA patient, right, it is so you have very well said that now we are moving toward less of nihilism in anaplastic CA, but we are yet very far from achieving a very positive attitude for this disease, right?
yes, sir.
So advanced directive means that if a patient with aggressive malignancy, advanced malignancy comes to us, we know that the patient is in the best condition today and they are going to deteriorate in future, okay, especially if they are aggressive or advanced tumors. So we have to gradually and a very considerate manner explain it to the family and the patient, and we have to know what our patient wishes about getting the treatment. It is very important. Okay.
Yes, sir.
What are patient choices? Many at times patient might not want to get any resuscitation done in the end. So this is, see, you cannot save an anaplastic patient in today's era with an advanced malignancy. So if it's an early stage T1, T2, it's a separate issue. And diagnosing those cases is mostly those are collusion tumors which get diagnosed on total thyroidectomy, right? Otherwise, what we usually see in OPD is an advanced thyroid malignancy presenting as anaplastic CA, right?
Yes, sir.
So these are important factors to understand. So these patients, we have to ensure that they don't land up with stridor. We don't have to embark on tracheostomy in these patients. That we have to ensure until unless we feel okay, tracheostomy is something which is going to be life saving, right?
Yes, sir.
Then, when important point, when biopsy is done, we should definitely consider sending it for IHCs and other analysis, but we should not delay our treatment waiting for IHC.
Yes, sir.
Suspect anaplastic, inoperable, send for radiation or chemo, whatever you can. In the meanwhile, when you are waiting for IHC, BRAF mutation you can get in 2 to 3 days if you have available in your setting. BRAF is important because most of the anaplastic tumors have BRAF mutation and they are targetable.
Yes, sir.
Right.
Yes, sir.
I just hope that people are getting what I am trying to say. Dr. Shikha, Dr. Vijay, am I clear what I am trying to say?
Yes, yes.
Thank you. So these are important considerations, Hannah. And apart from that, I don't think you have left anything. Most of the topics have been covered pretty well. Anyone else? So one important thing is that when you are dealing with an anaplastic CA patient, do ensure to have some surrogate decision maker for the patient identified by the patient. This is an important thing, especially if you work in a very high-end setting and where you get elite patients. This is a very important consideration, right? Advanced directives, surrogate decision makers. You have to identify them about any other future decision making for the patient when the patient becomes incapacitated for decision making, and that is going to happen very soon, right? So pretty much you have summarized everything. Important thing is if it is resectable, assess it properly. Okay, get a cross-sectional imaging done to see resectability. Get a PET scan done to see distant, to rule out distant mets. So these are two important things. No distant mets, locally resectable. Go ahead and resect it. So you will be able to do it within 2 to 3 days. Patient comes, get everything done within 2 to 3 days. Tell कि भैया ये resectable है. Post the patient tomorrow. Cancel all other cases. Next case is going to be this if it is resectable. If it is resectable to the extent that you have to remove a lot of visceral structures, preferably avoid that, because we really don't know if we are going to achieve any change in oncological outcome by doing that. So it's usually not recommended. But yes, suppose you are getting an absolute R0 resection with laryngectomy, you discuss with the patient. If the patient wants to go ahead, you can consider going ahead with that. Okay. Any iota on getting R, any iota of doubt of getting R plus resection, do not venture. Otherwise, if you'll do a grand biopsy and come out, the anaplastic CA will flow like a molten lava inside the mediastinum and destroy everything within 10 to 15 days. You will lose the patient within 10 to 15 days. Do not do R plus resection. R0, R1 is fine. Absolutely no R plus resection. Okay. Anyone else wants to make some comment? Dr. Vinay, Dr. Kunal, Dr. Shruti. Dr. Vinay?
Yes, boss. Yeah, very nice presentation. She has included almost everything. what he wanted to make a point was like if the treatments are done adds morbidity, then let's not do such kind of treatment, because anyways we are not going to give any survival benefit in this situation. So at least it shouldn't be a morbid procedure where its quality of life will be disrupted. Other than that, anaplastic CA, other than that, if it is a laryngeal resection with R0 resection, then yes, you can go ahead. But if it is involving esophagus, then I think it's a no situation for resections.
Absolutely, point well taken. Actually, even for larynx, I would say we should be very guarded when proceeding with resection. We have to explain it to the patient. If patient understands, this is like operating in a trial setting, right? Patient should understand there are very high chances of distant mets. There are high chances of failing the treatment. But if they want to, because we understand that okay, laryngectomy is still not as compared to esophageal resection. Esophageal resection is absolute no-no for anaplastic C. Absolute no-no. I think Dr. Vinay and we have made it very clear that no high morbidity surgeries for anaplastic CA.
Yes.
Anything else? I think.
Sir, in this no role of RAI, na?
No, absolutely no role of RAI. So see, RAI you will find a role in collision tumors. The tumor with differentiated factor as well as anaplastic, there you have RAI role. Otherwise, we know that, and Dr. Surbhi has put it pretty well, that anaplastic tumors lose all the factors of thyroid differentiation. You will not find TTF, you will not find PAX. PAX 8 कभी मिल जाता है, ठीक है, but there will be no other. It has no features of follicles of thyroid. Okay. It has no RAI avidity. Of course, no role of RAI.
So, sir, if a metastatic setting, if a PET scan metastasis is there, then is there we should go for operation so the patient should not go for obstruction, tracheal obstruction, otherwise we should avoid surgery.
Obstruction? I didn't get you.
This respiratory tract obstruction, sir.
So see, if the patient has distant metastasis, that is one criteria of exclusion for surgery for anaplastic CA. Okay, so you have to understand if it is lighting up on PET, it is more likely to be. See, anaplastic CA arises it usually arises in a setting of differentiated thyroid cancers. It most commonly arises in a setting of DTCs. Okay, so it is quite possible that the patient can be having metastatic DTC and locally anaplastic. This also we have to understand. So if it is lighting up on PET scan, it is less likely to be metastatic DTC and more likely to be metastatic anaplastic. That is why PET CECT is very important for anaplastic tumors. Okay. So if it is metastatic, no role of surgery usually, unless until it is very small, then also as such no role. You are saying about obstruction. We avoid tracheostomy as much as possible until unless there is an impending obstruction. It is a life-threatening condition.
So, sir, isthmectomy type or something is now at present उसका भी कोई role नहीं है ना?
No. So that is what it is an important question that you have asked. Surbhi discussed that okay, you can do near total thyroidectomy, you can do lobectomy. Okay. So these are not done. If you are doing surgery for anaplastic, you have to do total thyroidectomy at least with central compartment clearance. Okay, no role of lobectomy, no role of endo. If you will go inside anaplastic CA, you will do half surgery, you will come out anaplastic will flow like molten lava. It is a dictum of anaplastic. It flows like molten. Anaplastic and pancreatic flow like molten lava.
Okay, sir. So, sir, sequence we should do ki normal USG and FNAC followed by PET CT. If PET CT में there is no distant mets, then we will go for local staging, or parallel we should go for CCT neck along with PET CT.
Perfect. Absolutely correct. But all of these things we have to do it within a day or two.
Okay.
We will not wait for 1 week or 1.5 weeks to get the investigation done. Even in our setting, if a patient comes suspicious of anaplastic, अगर लगता है जरूरत to admit the patient so that we can expedite everything.
Okay, sir.
If you have any doubt कि anaplastic है, better to admit and so that it is expedited. ठीक है?
Okay, sir. Thank you, sir.
Anything else?